Okay, hello everyone, and welcome to join today's webinar. And my name is Xu Meng from the Journal of China Medical Devices. So, as some of you that may know that we will have the 13th China Medical Device Industrial Data Release Conference later this month in Beijing, China. So, it could be a better opportunity to have today's webinar and talk about one of really important survey that has been done since last year on the global clinical engineering body of knowledge and practice. So we are really honored today to have 5 distinguished guest speakers to join us. So now let's welcome our first speaker, Mr. Tom Judd, to share with us about the Global CE Body of Knowledge and Practice Survey. So now the floor is yours, Mr. Tom.
Thank you, Amy and friends. Glad to be here for the 13th China Medical Equipment Industry Data Release Conference, speaking about the Global CE Body of Knowledge and Practice Survey results and their impact for China. And so delighted to be with you again, as the past board chair of the IFMB Clinical Engineering Division, now on the Global Clinical Engineering Alliance Founders Council. A quick overview of what I'll be speaking about. I remind our colleagues today that we're speaking about the global clinical engineering community, which is IFMB CED and GCEA combined. And we did do a body of practice survey this past year. Many of you participated in it. Globally, there were, from the WHO 6 regions, there were about 900 participants in this survey. It's really our greatest and largest number ever. And China really was 20%, fully 20% of that survey, which is incredible, which and 21 provinces, colleagues there in China were participated, really 20% of the global survey. And so we have the results now. I'm going to share some of those. What are the opportunities for clinical engineers in China and beyond? What are some of the tools that we've learned from this work? And what's the scope of, perhaps our next steps? And we will be talking today about, some not only analysis of the survey, but perhaps China's response to the survey. Many of you know that the global community, GCEA, CED combined, has grown tremendously because we contributed so much during the COVID period. It's largely over, but we worked with the World Health Organization during that time. There's now over 630 collaborators from 210 or more countries. And those of you that are part of the global community realize that, and whether you're on the collaborator group or not, you're still a part of us for sure. And our collaborators from around the world include current and former ministers of health, physician and health system leaders, of course, engineers, medical physicists, technologists, technicians, professors, folks representing WHO and their regional offices, and, all over the world, and about a third of us are women. So a very cool group that you're a part of. This slide shows the survey response, the countries involved in the survey. And so it turns out, you heard me a moment ago say we have about 210 countries in our scope and in our community. Really, 2/3 of them participated in the survey. One or more representatives participated in the survey. So you see about 127 countries, a strong percentage of them in red there, hard to see, but low middle income according to World Bank's designation. And really a good, pretty balanced response across the regions. You see in the Americas, 32 countries, Africa, 29, 16 in the Middle East, 31 in Europe, 9 in our smaller region in Southeast Asia, and 10 countries, but a very large response in Western Pacific. And some of the immediate things that we saw in that were that our profession, and this is true for China, is young. 50% are under 40 years old. About a third, as I was saying, are women. Nearly half of our clinical engineering, that is biomedical engineers who serve at the point of care, nearly 50% of them have less than 10 years clinical engineering experience. And it turns out, what are the degrees, what are the education and background of the typical clinical engineers, those that responded to this survey? And you see the 15% associate degree, 35% undergraduate, 40% master's and above. And China, as you'll see in a slide in a moment, is at the higher end of that, tends to be more educated than many other countries. And you do have a credentialing program. You want many more to be a part of that. We'll talk about that. And one of the big things we've seen in the last survey was, I believe, 2017. So 5, 6, 7 years later, what's been the biggest change in our profession has probably been the rise of digital health. So I'm delighted to show this slide. Look at all the different provinces of China. Of course, I'm not an expert on all that, but a quick picture here showing this incredible response across 21 different provinces from China taking part in this survey. Here's a little bit of data. It's a pretty busy slide, but once again, it shows from across the nearly 900 respondents, 20 to 40 years old, 52% in China, even a bit younger, 61%. In how many years, what percent working years in the profession? 25% globally, actually 43% in China. You have a very young group. And I know you have many, many hospitals and many clinical engineers. And once again, you see a higher range of undergraduate and graduates than those in other countries. Some more of the data. You see what are the roles that clinical engineers play? Clinical engineer, biomedical engineer, those we typically think about those serving on the front lines in hospitals. About 15%. This is globally technicians and 15% professors. In China, 71%, pretty similar to the global, similar amount of technicians, roughly similar amount of professors. The need for digital health training and making us all wiser in those issues. Actually, there's a greater desire you can see sort of in China than there is around the world, because you guys are pretty leading edge in your practice. And then once again, many of you want certification. And I know there's some discussion if it were government sponsored, maybe there could be more, but I strongly recommend that you consider certification. This is a quick look against another region, a whole region of the world, the WHO Afro office area. And you can see there, the practitioners are a few less CEBMEs and more technicians and technologists, similar needs around global health and similar needs around certification. This is an important slide, and I know Alan and Li Bin and others want to see how this really impacts China. But we said, how do you build capacity? How do you build in more qualified clinical engineers to serve the hospital, serve your country? And 3 broad ways. I won't go into every point here, but through increased education and training and credentialing, through the health systems and the hospitals, both public and private's investment in you and your department and the tools that you need. And that as you need to continue to build your capacity. All of us have gaps in our backgrounds and in our training and education so far, but what are those gaps? What are those greatest needs? What do you spend a lot of time doing that you'd like more training on? That's the competencies part of this framework. So once again, knowledge, investment, and competencies, and some of the definitions on this slide, you'll get it later. So we can keep going here. So out of this survey, specifically looking at capacity building, what were some of the ideas that, and we had a town hall about this last October during Global CE Week, and we can share, but these are the things that came out of a lot of discussion with a lot of your colleagues around the world. We need to utilize this framework I just showed and the survey results to grow your talent, your capacity, your ability to serve. Certainly, we need to communicate well with health leaders, both WHO's health leaders and other health leaders, one of the in your country, in public and private health systems. We said the capacity building and the impact measurement teams are developing so-called evidence-based packages. In other words, we want to take a white paper, you might say, to your local provincial health leader, your local health minister, and show how you identify what their needs are, what are their health priorities, and then show evidence, show data of how you've been working on those issues. So that's a way to not only work with health leaders in your ministries of health, but also your WHO office, both for China and for the Western Pacific. And then think about who are your key healthcare influencers? I mean, it's academia, it's professional groups, it's certainly your industry partners, other health services leaders, to drive increasing awareness with health leaders. And we talked about alliances that can help build capacity. Certainly the one that US working with AAMI for global education and training, other industry partnerships that would help us grow capacity. A similar train of work last year was our impact measurement. How do we, we all have indicators. I'm looking in the upper right-hand side of the slide. We all have activities, how much preventive maintenance, how much repair do we get done? How much planning do we get done? And those result in, more ready equipment to serve. But when you have more ready equipment to serve, how does that actually impact clinical outcomes? And how can you measure that? And, in this work with impact measurement, we use this theory of change model. That's a little bit of it's displayed in these boxes up in the upper right. But I'm excited to remind you that a lot of our great studies, our evidence for impact measurement did come from China. You see some of these you see 8 different studies identified at the top right here around safety, quality, access, health systems, and innovation and digital health. But you see 5 studies from China, one around personal protective equipment from Shanghai health system there, 120 hospitals that Li Ben works with. And again, you see measurable impact on outcomes of the health system for safety quality from Shanghai's Quality Center, more around their infection control guidance, and then the work in Hangzhou, and then the work around digital health in Lijiamen, and the safety and quality around ventilator alarms and neonatal intensive care from Allen's location. So we've had some great studies already, but we need to get more of those, and we need to connect that impact measurement and our discussions with WHO and their definitions of improved quality and clinical outcomes. And we will continue to do this work and continue to publish about it. Getting close to the end of my time here. Let's see, how am I doing? About a minute here. So what can you do now? Well, we'll talk about this more in the discussion at the end. Submit abstracts for our upcoming Congress this fall. In November, utilize the framework that I talked about and the results to grow capacity. Some specific, you can seek certification through CSCE. If you haven't already taken the survey, we can make that available through Amy on the app from China Medical Devices. What were the topics, though? You may remember, those of you that took the survey, and many of you did, there were 40 different topics where you could say, I worked on this, or this is what my greatest need is, or my greatest importance in my practice. And I'm excited to tell you today, and this has just been released, that the top 6 issues where you had 90% of you said this was moderate to high importance was in the area of medical device regulation, the area of maintenance, the area of quality, the area of data management, risk management, and what we call clinical engineering IT, the relationship between clinical engineering and IT. And with that work, we can develop more awareness with health leaders, identify and work with health influencers, and work with GCEA, particularly to address education and training needs. So with that, I'll just remind you, there was a report in the Global Clinical Engineering Journal last December about the great work that our profession did, our community did during COVID, and you can see that there. And then finally, thank you so much. Over to you, Amy.
Thank you. Thank you, Mr. Tom. And thank you so much for the presentation. And then this survey is definitely a really good start to get a better and clearer images on the global CE community, and also provide us a really good direction to work on in the near future. So we will have Tom back with us in the discussion session soon. So now let's get more insights from China, and let's welcome Mr. Zheng Kun. And today he will present the hospital CE development in China from perspective of two surveys. And Mr. Zheng Kun, the floor is yours.
Okay, and thank you, Amy. And hi, everyone. It's my pleasure to talk and give a glimpse about hospital clinical engineering development in China from perspectives of two surveys. This presentation was prepared by CSCE Chair Professor Li Bing and his student Tong Jing and myself as well. Presentation summary. First, white paper of career development of clinical engineers in China by GCEA in 2020. Second, clinical engineering body of knowledge and body of practice survey, part of GCEA's 2022 global survey. And the third, some observations and discussions. And this is a white paper on career development of clinical engineers in China, published by CCE in 2020. And this one is based on an in-depth survey with effective 1,200 samples and 5,000 clinical engineering staff involved. And the main contents focused on the professional development and evolution of clinical engineering in China, and also the status quo of clinical engineering in China, and also the career development and prospect of clinical engineering in China. And according to this white paper, there are about 36,000 hospitals are above hospitals in China, and in which about 28% are belong to tier 2 hospital and 8% are belong to tier 3 hospitals. And there in total about 94,000 clinical engineering professionals in the hospitals above tier 2. That is to say, on average, there are about 15 people in a tier 3 hospital and about 6 people in tier 2 hospital. And this is the clinical engineering practitioners' education background and degrees they hold. And this slide shows the most in-house clinical engineers education background are biomedical engineering, and also there's some the EE, mechanics, computers, and most of the current clinical engineering practitioner hold the bachelor degrees. That percent is about 60% based on that survey. And this is workforce age and the professional technical title they hold. And more than 80% within the age group of 26 to 55 years old. And the majority of them, they hold the medium professional titles, that is the clinical engineer, and only 10% with high titles such as a senior clinical engineer and professor level senior clinical engineers. And also the white paper divided the Chinese in-house clinical engineering development into 3 stages, namely the fundamental stage, established stage, and advanced stage. And in the fundamental stage, we believed in China, the first in-house clinical engineering program established in middle 1970. And more was set up later from 80s to early 90s of last century. And it was mentioned that the advanced stage is from the 2010. The reason gave that particular year, and I believe is one reason is because during that time, So CSE, the Chinese Society of Clinical Engineering, conducted a lot of the cornerstone clinical engineering activities and events. And the second reason is in that year, the MOH, Ministry of Health in China, issued a regulation on the safe use management of medical devices. In that regulation, it first clearly states in hospitals there should have having the established clinical engineering programs. And these two photos showed the WHO medical device official Adriana and the then VP of EQUI, Jim Keller, visited us at the hospital in Hangzhou. And this is another reason we mentioned the so-called the advanced stage, because after the year of 2010, the CSE developed BOP of in-house clinical engineering, and it's very comprehensive. From these slides, you can see it covers from the medical device budget developing and the purchasing and incoming test, and also the other like programs such as the quality control, safety management, and also some education research, and also some of the clinical engineering innovations. And this is a white paper's actual survey about the BOP. And according to the white paper, a very typical model for the in-house clinical engineering program in China in terms of the quality control for the medical devices is a so-called three-level networks in terms of the people, process, and technology. And that is the first level is the hospital administration level. There is a clinical use, safety, and quality management committee. And of course, the second level is the most important, and the key part is the in-house clinical engineering program. Plus the third level is a frontline. Every department, they are assigned some medical device managers from the clinical team. And by established policy and procedures and assisted by some of the information tools like the MEMP, CMMS, and through the multidisciplinary teamwork approach, and through the communication, collaboration, commitment to conduct the in-house clinical engineering program to ensure the medical device are safe and effectiveness, and also promote the patient care. And also the typical CMMS nowadays used in most hospitals in China above the T level are so-called the cloud-based CMMS. And that is every capital piece of medical equipment has a unique QR code. By scanning this QR code, you can access on-site like the operation guidance, the quality control programs, the preventive maintenance data, etc. And also you can initiate troubleshooting requirement. So this CMMS system facilitates the management and the tracking of equipment status and quality control information. And some of the top hospitals in China nowadays invest a lot of the money to establish information infrastructure through the 5G, Internet of Things, digital twin technologies to conduct the medical device online real-time monitoring. So part two, just like Tom Judd mentioned in depth, so I'm here is mainly focused on part of the BOK and BOP survey in the digital health domain, because part of the survey is to ask the respondents to answer the two questions: which fields of digital health are involved in your work, and which fields of digital health do you think need training? And of course, this is the respondents' profile from China. The young generation aged 20 to 30 accounted for the largest portion, followed by the people aged 30 to 40. And also among those surveyed, 27% were women, while men accounted for 63%. And it's very interesting if we compare this survey to the year 2020 survey by the GCEA, the educational background is pretty same, but the landscape changed a little bit. And that survey shows the most clinical engineers in China hold the bachelor degree. That percent is like 60%. And this small sample shows this number decreased a little bit, like 55%, while the master above degrees is rise. And these are the two tables results related to the two questions I mentioned. And part 3, some observations and discussions. Both surveys show that the overall group of Chinese clinical engineering practitioners in hospitals is very young. 60% plus is below 14 years old. That suggests the future of China's clinical engineering is bright with plenty of young generation human resources. 2, it is worth pondering that women account for 20%, though we observe that more and more women join the clinical engineers in recent years. How to encourage more women to join the workforce of clinical engineering, still waiting to see. 3, interoperability of devices or systems, device or system reliability and integrity. Decision support systems or artificial intelligence, health informatics, database or data analytics, and cybersecurity rank high in both survey tables. And these 6 technologies have been gradually widely used in hospitals, but due to relatively new technologies' nature and shows insufficient knowledge reserves. 4, in the survey is a ranking of network security, robotics, wireless facility design, or institutional connectivity in the two tables are basically the same. The speeding application of new technologies is basically consistent with the very required trainings for clinical engineers, which is in line with the reality that the current professional knowledge of digital health is insufficient, and relevant knowledge and capacity building needs to be strengthened. 5, the survey may not represent all clinical engineering personnel, in particular, those tier or even smaller hospitals, plus challenges such as how to address risk management and quality control on new emerging technologies within the domain of digital health, such as artificial intelligence and software as medical device in hospital settings. Relevant items are not covered in the survey. So to conclude, I just want to point some of the unique features and common challenges and opportunities we facing the Chinese clinical engineers. The first is the medical supplies, the disposables such as syringes, tubings, management are also within most in-house clinical engineering program. The second is also comparing with our international counterparts, professional titles in terms of clear growth, such as promotion of engineer, senior engineer, and professor level engineer for Chinese in-house clinical engineers is unique and important. Yet compared with our other healthcare professionals, such as physicians, nurses, it is still a great challenge for CE in China in many provinces. And some of the common challenges and opportunities, just name a few, like CIT convergence, medical device cybersecurity, and clinical engineering innovation. Therefore, enhancing clinical engineers' capacity building is extremely important because the CSC led by the Professor Li Bing, we have very clear objectives for the current clinical engineers in hospital to be the integrate for advanced medical technology, a planner for hospital development and operation, guiding for hospital medical technology safety and quality, data analyzed for the digital diagnosis and systems, and also be a participant for medical device and clinical innovation. With that, I want to thank you all very much. Yeah, thank you.
Great. Thank you so much, Mr. Zheng Kun, for shared with us more detailed analysis based on this BOK and BOP survey, and with the discussion actually in the last few slides that I think they are all really valuable and could be, and like each of them can be a really good topics to expand for discussion in the future. So now let's welcome Mr. Tom and Zheng Kun back with us again. And also let's welcome our old friends to join us in the discussion session. So Dr. Yadin David, Professor Li Bing, Ms. Lo Xiaoming to join us. And hello, everyone. Okay, really nice to have everybody back with us again. Okay, so so we actually have the first question that would like to ask my international friends here, Dr. Yadin and Tom. So as we heard from Tom's presentation at the really beginning for the BOK and BOP survey, as well as the GCEA and FNBEC, these ongoing projects. So in particular, the capacity building project. So one of the next step is to do is for us to actually utilize the capacity building framework. So just to get a little bit deeper in this. So from your perspective, Dr. Yadin and Tom, how to make the capacity building framework a practical tool that can enable clinical engineers teams to have a self-evaluation and keep improving as well. So maybe Dr. Yadin, good morning. And I understand that it's really early morning for you to join us today.
Still dark outside, but it's great to be with such a good friend and very knowledgeable people in the field. Excellent presentation by Tom and Zheng. One more internationally oriented and the other one is more Chinese particulars. And it was very interesting for me to learn about the differences between the two. If you look at the specific feature, one item that is called capacity building, what is missing is the specific reason. Capacity building can be just a project that can run endlessly with no goals and no target. However, what we need to do is to begin with identifying what the needs are. And when you know what the needs are, you look at the gap of what you have as current resources and where do you need to be. Let's say that in China, Zheng Kun told us that there are about 94,000 hospitals, and half of them is fully equipped with competent clinical engineers. The interventions are done well. System security, reliability, and interoperability are all well attended. Capacity building is not useful in such situation. But the other half of the hospital, and that's just a theory, hypothetical theory, we need to establish the goals. Do they need to reach the same level? Are they different tier system and the target are different? So the framework for capacity building, in my opinion, has three main categories. One is for the individuals. What the competency of those who are working in the field should be like. The second one is the system, what the hospital tier is. hospital that is rural area have different needs than hospital that is in the major metropolitan large city medical center. And the third one is the healthcare system in general. And what we need to do, we need to be smart to demonstrate that when you do have competent clinical engineer, the intervention, the patient experience, the outcome of the healthcare system are much better because of the clinical engineer that is that are working there. If we cannot show the difference between when you do have clinical engineer, even competent one, and when we don't have clinical engineer, then capacity building has no end, no target. And that part is still missing from our discussion. So in answering your question, one last bullet is that capacity building project is something we all work on. However, we need to identify what is the end goal, what are the needs, and what is the difference in the requirement between the different tier system, the major medical center, and the rural environment. Thank you.
Thank you, Dr. Yadin. And it seems like we have a lot of work to do based on that as well. Mr. Tom, do you have something to address on this?
First of all, a great presentation by Jinkun and very wise comments by Yadin. We've begun to give some tools to be able to do what Yadin has said. He said, what are the goals at both individual, at your local health system and healthcare in general? What are the needs in those three levels, and what are the gaps? One of the things we said was put together for your health. Let's start with the health system where you are locally, as well as think about health system in general. What are the needs there locally, as Yadin has just said? What are the health priorities is another way of saying it. Is it chronic disease in that local province? Is it communicable disease like COVID or other communicable diseases such as that? What is it? Heart surgery? I mean, that's related perhaps to chronic disease for cardiovascular. My point is, what are the local health priorities? And then begin for maybe that provincial health leader or that hospital leader to show how clinical engineering has made an impact on that. And we've given some examples of that in our global community work. GCEA and CED are beginning to give example white papers. And so I would say, what are your health system needs? And then what are the competencies that the clinical engineer needs to be able to contribute to that? Show the evidence of what's already happened, but also begin to work on the competencies needed to assist those local health priorities. And so, for example, what I saw, and in my 15 minutes earlier, I only left about 30 seconds to say, what did Chinese clinical engineers say the competencies they needed to address local health priorities? And I'll remind you, and they'll ring true to you when you hear them again. Regulation, is there a difference between the provincial regulation and national? Maintenance. Now that affects all the tiers that Yadin was talking about. That was number 2, regulation, maintenance of equipment, maintenance management. That will change as those tiers change. Quality management. Now, Li Bin at the health system level in Shanghai, 120 hospitals plus, has a quality control approach that's well documented. So that's one way of looking at quality. Quality of clinical outcomes is another way, but how do people get competencies in those areas to replicate things that Li Bin has across many hospitals in Shanghai? People want to know more about data management. We all hear that there's this rise of clinical, data, business and clinical data available. How do you best use that to convince health leaders you're doing the right thing? Risk management. You don't want me to talk about all of these, but clinical engineering, how it interfaces with IT as we get data into electronic health records and do a lot of other things. These are all competencies that the clinical engineers from China in the survey said were the things they have to do. And we've got a lot of resources. GCEA has got a lot of resources out about these topics, but how do we get them to the right people, you know, in the right tier? And by the way, Jin Kuhn also mentioned innovation and cybersecurity. If, you know, I told you the top 6, well, they're in the top 10, those last 2, innovation. So anyway, I'll stop, but how do we, where the gaps are at the tier, how do we grow the competencies that will help make a difference there locally? Over.
Okay, thank you, Tom. Thank you, Dr. Yadin. And then, so I guess now we can start hearing our China's representatives on their thought on this topic. And I'm sure that our audience, both at home and abroad, are really interested to hear from you all. So still about the capacity building. So what are the top topics for Chinese clinical engineers needed and expected from for learning and best practice that can share with our audience today? So maybe we can start with Professor Li Bing.
Yeah, thank you for the Professor Tom and the Yadin. And also, as we talked about the PPT topic, we know that as Chinese clinical engineers are younger than the global clinical engineering, we need more education and more training. And also with the rapid development in China, we need more the skills and the experience, especially for the medical equipment maintenance. This topic maybe cover the technical skills needed to repair and maintenance medical equipment, such as diagnosis, imaging machines, and the surgical instrument. And also for Chinese clinical engineering, we can learn a lot of the best practice and to preventive maintenance, calibrations, and troubleshooting. And more recently, our clinical engineering more interesting in the biomedical technology innovation, with China's growing emphasis on the research and innovation. Biomedical technology innovation is a crucial area for Chinese clinical engineers to focus on. This includes learning about the emerging technology such as artificial AI and also machine learning in healthcare, and also as well as developing skills in promoting prototyping and testing the new medical device. And this is very hot in these years in China. And also they have some IT. We need some training. Also including the HIT is becoming increasing important in China in the healthcare, and the Chinese clinical engineers should be very familiar with the latest development of the electronic health record, and also telemedicine, and also about some HIT solution. This including understanding how to integrate the HIT system with medical equipment and devices, as well as to emphasize data security and privacy. And then last, we should do the interdisciplinary cooperation. As the healthcare becomes more complex, Chinese clinical engineer needed to be able to work efficiently with other healthcare professions. How we can learn about your country, other countries, how to build the relation between the physicians and the other specialists, and we can do more developing communications and cooperation skills, as well as learn about the different roles and the responsibilities of health teams members. That's all. Over. Thank you.
Okay, thank you, Professor Li Bin. And Ms. Low, do you have your thoughts on this?
Yes. Thanks again, Tom. Thank you for the birthday greetings. And I agree with what Dr. Li Bin just said. I agree with his opinion. And apart from that, I think cross CEIT related capability is very, very important. Compared to 10 years ago, information technology is getting so much closer to our life and work. Digital health applications, networked workstations, AI applications, cybersecurity issues are everywhere. Nowadays, students in high school are studying Java and Python, and we clinical engineers, we lack capability in information technology now. Actually, not only in IT, it seems we clinical engineer should learn so much more to follow up with the fast developing technology. Our BOK needs to be updated often. Another situation is that we are increasingly dependent on the services of manufacturers, and in some hospitals, clinical engineer departments are outsourced. How to meet the growing needs from the hospital? And here I have an idea, and I'd like to hear your opinion. It is that maybe we could consider to refine the division of labor of clinical engineer. As in doctors, there are general practitioners and specialist doctors in so many different departments. And for nurses, there's also a specialist nurse training and management system. In addition to general practice nurses, there are also specialist nurses such as hemodialysis nurse, peritoneal dialysis nurse, diabetes specialist nurse, wound managing nurse, ICU specialist nurse, PICC specialist nurse, and pain specialist nurse, etc. They will face different problems at work, so they need to learn different skills to handle the problems. They are trained differently with different BOK, get a certificate in order to be qualified. Maybe it is time for us to train CE specialists. For example, CEs in the OR should know more about laparoscopy, digital signal transmission, surgical instruments, disinfection management, medical gas management, or even OR information system. While clinical engineers in the dialysis room will have to learn more about hemodialysis information system management, photoelectronic signal conversion, management of RO water system, and control of nosocomial infection. And in the X-ray, clinical engineers learn more about the capital equipment and DICOM and RIS, of course. So is it possible for us to develop a training system based on different needs of CE field? This system help build up more specialists in the CE population and let us be heard more and make us stronger. This is my opinion. And I just noticed in Mr. Zheng Kun's speech and also Tom's speech from Global 2022 BOK and BOP survey globally, 25 to 30% women CEs. I have some interesting information to share with you today. The theme for International Women's Day, the 8th of March, 2023 is Digit All, Innovation and Technology for Gender Equality. This theme is aligned with the priority theme for the upcoming 67th session of the Commission on the Status of Women, Innovation and Technological Change and Education in the Digital Age for Achieving Gender Equality and the Empowerment of All Women and Girls. A According to a set of data disclosed on the official website of the United Nations, as many as 37% of women do not have access to the internet. Countries around the world are now placing great emphasis on talent development in STEM fields. STEM is an acronym for 4 subjects: science, technology, engineering, and mathematics. Clinical engineering is obviously part of STEM. It is predicted that by 2050, 75% of jobs worldwide will be STEM related. And as I know, if a girl student applies to a STEM-related college or engineering major in the US, she gets more opportunity than a boy. That is a good news, but that is also because women generally represent fewer than men in research and work in STEM fields. According to a report released by the World Economic Forum last July, women occupy only 22% of positions in artificial intelligence, which is quite similar to the percentage of women clinical engineers globally. The Global Gender Gap Index aims to benchmark progress towards gender parity and compare countries' gender gaps across 4 dimensions. They are economic opportunities, education, health, and political leadership. These data show that in the digital field, there are significantly fewer women than men in both education and employment opportunities. And Iceland is the only economy that has narrowed the gender gap by more than 90%. The 10 best performers of the Global Gender Gap Index are Iceland, Finland, Norway, New Zealand, Sweden, Rwanda, Nicaragua, Namibia, Ireland, and Germany. The US ranked 27th, while China ranked 102nd. What could we do to close the gender gap in clinical engineering? Is it possible to develop policies to give women more opportunities, such as women getting a discount to the training cost, giving rewards or award to regions or countries where more women clinical engineers participate in activities, or at least above average, and reserving certain percentage of female seats in clinical engineer activities. These will be the suggestions that I have to say today. And Yadin, Tom, and Mr. Zheng, Mr. Li Bing, thank you all for doing this BOK and BOP survey. It must be a very tough job, but it means a lot to the future of clinical engineer globally. Over. Thank you.
Okay, thank you, Ms. Low. And then you also posted really interesting points here. Mr. Zheng, would you have something to add?
Yes, I have 3 quick comments. The first is Dr. Yadin David just mentioned a very important issue, that is different areas, different level of hospitals, different status quo of the in-house clinical engineering team definitely have different requirements for the capacity building. And Professor Li Bing also anchored that. Yeah, and the second quick comment is, so Tom, Judd, I still suggest that you should develop a tool, an online self-evaluation tool for the in-house clinical engineering, and based on the capacity building module, and so can promote the international clinical engineering, I think. And the third quick comment is I was thinking the CSCE and GCEA may co-host some of the webinar and especially address some of the Chinese clinical engineering professionals interested topics. And also arrange the time is convenient for the Chinese clinical engineering professionals to attend Like I noticed the GCEA and the CED conducted a lot of the capacity building webinars, but mostly I mean in the midnight in the Chinese time, so it's not easy for us to access it. And also we may invite some the in-house clinical engineering program in US like Ilya Kluri, or some of the other hospital like Mayo Clinic or even the Johns Hopkins Hospital. I know they have a very good in-house clinical engineering programs to share some of the best practice. Also, like Professor Li Bing can share our international counterparts, because Professor Li Bing his team has already conducted a lot of the national level awarded research projects. And also like Ms. Feng in the Johns Hopkins, they established their in-house clinical engineering program. They established a provincial level recognized key medical device evaluation lab. And those best practice by sharing with each other is very important. Also, we may need to address some of the topics. So lower level hospitals, a small in-house clinical engineering team, like they may be interested in the how to quality control, how to do a preventive maintenance on specific piece of medical equipment, etc. Yeah, so that's my 3 quick comments. Thank you.
Okay, thank you, Alan. Thank you. And Tom and Dr. Yadin, do you have something to respond to this today? Or I know we have a limited time here. Yeah.
You never offer me the microphone.
Here's yours.
First of all, I want to congratulate Lu Xiaomin. Excellent points. I don't know where to start, but reminding us of the International Women's Day that has been celebrated yesterday is great. It's very appropriate. Reminding us that we need to do more work on gender parity and equality is something that the Global Clinical Engineering Alliance assigned a subcommittee to deal just with that issue. And on the website, there are already material to look at and see where the Alliance is going to be moving with covering this topic. Secondary, the idea of general practitioners and specialists is very appropriate to the field, because so much knowledge is created. It's impossible to be expert on all of that. You can be generalist on all of that, but you need to be specialist in particular example, a particular field. The dialysis and the imaging are perfect example of specialty. Li Bin visited my department at the Texas Medical Center, and he saw that my department was structured just like you're saying, a generalist who are seeing the management of the assets and the overall operation, and then specialized CEs on dialysis, on imaging, on surgeries assigned to those roles. So I want to commend you for making those comments that are very appropriate. As always, Zheng has good analysis of information and suggestions of where do we go from here. The topics and the priorities are going to be part of the 5th ICE HTMC come November 1st in India. And I'm encourage you to promote the Congress throughout China and submit abstract to the Congress on those subjects, and show us what the gaps are and how you're going to address them, as well as write full papers for the Global Clinical Engineering Journal that now has a Chinese version running simultaneously. We are proud of that. So with that, I thank you for giving me the opportunity to be part of this panel.
Thank you, Dr. Yadin. And Tom? Yeah.
Very quickly, I just echo Yadin's comments. You saw my note in the chat about we're moving towards near parity on the scientific committee for the Congress, with nearly 50% women on a very large group that will guide the content of this program. Similarly, for clinical engineering specialists, the Kaiser Permanente, I came out of a very large group like Yadin did in Texas Medical Center and Kaiser Permanente. And we were also ordered along the lines of these specialties that Lo has talked about. And come and submit abstracts for the Congress. We're looking forward to it. Thank you.
Okay, thank you so much for everyone to join today's webinar, and hope that we can have you back with us in the near future to discuss more on the development of the clinical engineers. And just like what Dr. Yadin always said, together we can make it better. So thank you so much again, and hope today's webinar has provided you a better idea of the status of global clinical engineering community. And to just quickly sum up and highlight some of the key information here. So for those of you who may interested to know more details about the BOP and BOK survey, so you can always check on our Global Clinical Engineering Journal. So here, the volume 5 and issue 2, there's a engineering report that you can get more insights about the survey. And also, in fact, in the past few years, the FNB, CED, and GCEA has continued work on identifying the status and the need of the global CE community. So, and their previous survey results also published on the Global CE Journal. And for example, here showed volume 2, issue 1, and volume 3, issue 2 that listed here. So you can always read those articles for free on the official Global Clinical Engineering Journal website. And I hope that all of us today already know about this journal, but just in case this is something new to you. So the Global Clinical Engineering Journal is a diamond open access and publishes high quality and timely double-blinded peer-reviewed manuscripts about the intersection of technology, engineering, and informatics related to health, wellness, diseases management, and patient care outcomes around the world. So here's the website of the journal, and we are highly recommend that you to check it afterwards, and then also looking forward to see your exciting ideas being published here on the journal as well. And the next is about the 5th International Clinical Engineering and Health Technology Management Congress. So the first year of the Congress was actually held in China in 2015, and then the Brazil in 2017, Rome in 2019, and the virtual conference because of the pandemic in 2021. So this year it will be held in India actually from November the 1st to the 4th. So now is actually a really good time for you to prepare the abstract. And here are the listed topics that you can consider. And you can also submit the abstract on the website that's listed here. And the deadline will be the May 15th. And you can always go and visit the Global Clinical Engineering Journal and check the previous conference proceedings actually. So you can see what topic that has been discussed in the past. And also FNB CED also call for case studies and stories of women in clinical engineering. So if you have your personal stories that would be like to share with the international fellows, so please submit them before March 31st. It's actually really close. So yeah. Okay, that'll be all for today. And thank you so much again for joining us today, and looking forward to talk to you in the near future. Thank you. Bye.